Ryan Stanton here with ACEP Frontline, and today we have a Pedsapalooza from the ACEP Accelerate Pediatric Emergency Medicine Assembly. This is one of my favorite conferences. If you have not done it, you absolutely need to do it. Even if you're not PEM, I am not. I am a community emergency physician, but it is a fantastic conference. One of the best group of presenters / faculty of any conference that I go to. Consistently high yield information as well as entertaining. You'll see it here in these conversations. So basically what I did at the conference in San Diego is I threw the mics on them and let them go for almost the entire midday session. And it did not disappoint. So it's a little bit longer than most of our usual podcasts, but once again, well worth it. Welcome to our 2026 Pedsapalooza from ACEP Accelerate, the Pediatric Emergency Medicine Assembly.
All right, we are going to talk about backyard envenomations. Sean came up with this title, not me, so in my backyard, it's my cooking, so that's the more dangerous thing in the yard. All right, obligatory definition: envenomation, the act of poisoning which occurs when an animal injects venom into another organism through a bite, sting, or other puncture. Fair enough. This excludes politicians, attorneys, and hospital chief financial officers. Snake bites. Here's the obligatory statistics. 140,000 deaths per year. United States, there's 8,000 bites a year. 5 to 10 deaths for arthropods. 72 to 100 deaths worldwide. Anaphylaxis is the #1 cause, and children predominate. And the main reason being the animals that are biting them are full size, and most of the toxins are proportional to the size of the person being bit. So if you're a rat, that's a whole lot of poison that's going to kill you. If you're a child, that's enough to kill you. And an adult, it's probably going to make you incredibly sick. All right, classification of venomous snakes. All right, this is, who cares? The only thing is the damn thing bit a child, and now they're in my ED. So particular species does matter. So it really, normally it's just like, I got bit by a snake. Okay, it's a snake, it's a snake. I don't care. You're here. Let me figure out what to do. But it makes a big difference what bit you. And the reason is the following. There's two main classes of snakes. There's the elaptids, which are things like coral snakes, and then there's the pit vipers. These are rattlesnakes, cottonmouth, and copperheads. And they are in different parts of the country. The coral snakes are more north or southeast. And the big thing with them is they have neurotoxins. So if you get bit by one of these, what you're going to get is neurologic symptoms, a descending paralysis, numbness, those kind of things. The pit vipers, on the other hand, have some neurotoxins, but most of their stuff is bioactive proteins. They're things like prothrombins, anticoagulants, various inhibitors. And they produce a lot of local tissue damage and a lot of hypotension and coagulopathies. So you're going to see different things depending on what bit the child. In terms of first aid advice, there's none, okay? What's really interesting about that is there's no evidence-based medicine that anything you do works. That doesn't stop eBay and Amazon from selling these kits. There's the clip-on snake bite kit. There's the snake bite kit that's combined with a bee sting kit. So if the snake was biting your leg while a bee was stinging your arm, you'd be all prepared for that. And then there's the cutter snake bite kit, and that's expensive. That's $34.99. And the thing with that is it's got the scalpel, so you can cut the X incision over the bite and then suck the venom out. Bottom line is none of them work. So don't go buying some the next time you go hiking, and don't advise it to your patients. Main thing is reassurance. Now, there is some data that if you put a pressure pad on it, you can decrease the absorption rate, because what you're really trying to do is clamp down a little bit on the lymphatic tissues that are going to carry the venom systemically. So the idea is you put a 4x4 on there and wrap it with a bit of an ACE wrap, but that's about it. Immobilization decreases the flow up the lymphatic system as well. So if you're walking, your lymphatic system is going to pump more effectively. And that's not what you want to do. So you want to immobilize them, particularly if it's the lower extremities. The most important thing is between 10 and 80% of bites are dry bites. Again, this is a ridiculous range of numbers. Either it's, oh, you got no shot that you got any venom in there, or you got about an 80% chance that that snake put some poison into you. So this doesn't really help, although it does depend on the time of year. If the snakes, particularly the pit vipers, are just coming out of their winter kind of hibernation, they're a little bit more likely to have concentrated venom than if they've been out and about for a while. All right, beyond local wound care, the treatment is going to be antivenoms. And these are enzyme-digested immunoglobulins. So what you do is you take some animal that doesn't know any better and you inject them with small amounts of the toxin until they build up antibodies, then you harvest the antibodies. There's two types. There's the Fab, and then there's the Fab AB squared. The two of these are different only because the Fab AB squared is a smaller molecule, but it lasts longer. So that's the only advantage of it. But it's pretty much whatever you can get from your local poison control center or your local zoo is what you're going to use. And then you give a small amount of a test dose. If they don't get an anaphylactic reaction, then you can administer it. It is very dependent on where you live. If you live in an area that's got a lot of endemic types of snakes, particularly rattlesnakes, you're probably likely to be familiar with how to get a hold of the antivenoms. If you're not, if you're in an area where there aren't too many rattlesnakes, but there's some goofball who's got a pet rattlesnake that they tried to kiss and then it bit them on the tongue, and now they've got all kinds of problems, that you're going to have a little bit of trouble tracking down the antivenom. The place that will always have it is going to be either the poison control center, they won't have it, but they'll tell you where to get it, and the local zoo. All right, the indications are based on your systemic symptoms for most of them, but not all of them, and we'll talk about that. Hypotension, neurotoxicity, coagulopathy, so you see if they're bleeding, and the place where these people bleed is their gums. So if they get bleeding in their gums, it's usually from one of the rattlesnake bites or that type of bite, that's an indication to go ahead and give them the antivenom, hemolysis, and then shock, obviously. If you have severe local reactions, so again, this would be the only time it's not systemic, but it's a local reaction, and you look at it, if they have swelling greater than 50% of the limb, if it involves the fingers or the toes, rapid onset of symptoms, and it's a known necrotic venom. This is not so much of a problem in the continental United States as it is in some of the African snakes are incredibly venomous, and there's some snakes down in Australia as well. All right, mostly it's supportive care. These are the problems that you can have, and then it's supportive care just like you would for anything else. Obviously, if there's paralysis, you're going to want to support them. One of the things you can do is a tensilon type test on these people, where what you do is you take an ice, so if they're beginning to, I feel weak, I feel tingly. Part of the problem is if they're anxious, they're going to be hyperventilating, so they're going to feel tingly as well. But you take an ice pack, and if they're getting some ptosis, then you put it over the eye. This is similar to what you do with myasthenia gravis. And if the ice pack over the eye improves the ptosis there, that means that they've got a significant amount of venom in there, and they should be treated with an antivenom. Cardiovascular, it's mainly fluids, vasopressors, and the usual antiarrhythmic therapy. Bite wounds don't get infected. They get a lot of swelling around them, a lot of redness. It's not bacterial, so there's no real need for antibiotics. Limb care, like we said, splint, immobilize them. Don't elevate them. Again, you don't want to get whatever's in there back into the systemic circulation. You want to leave that limb immobilized, and you don't want to assist the lymphatic system in moving things around. And then eyes, you treat with a chemical injury, irrigation, corneal abrasion care, and the usual stuff. All right, that's it for snakes, bugs. Probably going to see more bugs than we are snake bites in most of our practices. And the bugs come into two categories. There's a Hymenoptera. These are the wasp type things, and that's the yellow jacket. And anybody here who has not seen a yellow jacket in their neighborhood, I'd be very surprised. They come out year-round, or in the warmer months, spring, summer, fall. They're more aggressive in the fall. And the reason they're more aggressive in the fall is during the summer, as they provide food to the queen in the hive, she secretes a sucrose solution, a sugar solution to them that they eat. As you get into the fall, the queen stops making eggs, stops secreting any of this sugar solution, so the bees, the yellow jackets go out looking for it. And this is why if you go to the picnic and you wind up with all these yellow jackets around you, what people will tell you if you talk to the entomologists and stuff, they'll say, take a shallow plate and put some sugar water in it about 10 yards away from your picnic, and that will attract, the bees will go there, and they'll leave your pretty much your mayonnaise sandwich alone, so you can get food poisoning from that without being bothered. The venom has enzymes in it. It's got some amines, and people digest these things and look at all the things in it. All you need to know is that it hurts like hell. There are some neurotoxins in it. Now, most bees or stinging insects along those lines, it's not the toxin itself unless you're a small child and you've got stung a lot. Most of it's going to be anaphylaxis in these things, and that's going to be the main thing that's going to cause the problems. And the thing is, you have to be previously sensitized. So the first time you're stung, it's not going to be anaphylaxis, but the next time is when you may get it. One of my grandkids is highly allergic to the stings, and he's had one anaphylactic type reaction, so he carries a bee sting kit with him wherever he goes. Treatment for bees, remove the barb. Now, bees, when they sting you, they lose the stinger. It's one and done. And there's a little muscular ball at the end of it that pulsates, and that's what keeps injecting the venom into you. And it used to be taught, for God's sakes, don't use forceps and pull the thing out. And people do anything to publish an article. These guys did something where they put their arm in a glass container with a bunch of bees, got stung, and then they looked at some of them, they just grabbed the stingers and took them out with forceps, and the others, they used all the other techniques that are out there. You're supposed to take a credit card and scrape along it, and that's supposed to pull the stinger out and stuff. What they found was it didn't matter how you got it out. What mattered was how quickly you got it out. So if the forceps got it out quicker, even though you were squeezing that little bulb as you pulled it out, the tip of it is so tiny, the hole that it's coming out of, that it was better to just get the thing out of there than leave it in there and let that bulb keep squeezing it. So forceps are the way to go. Vespers are the wasps. Now, wasps can sting repeatedly because that's what they hunt with. So what happens with those is, if you get stung with a wasp, don't go looking for the stinger. So when the parents bring the child in and say they got stung by a yellowjack, don't look for the stinger on it. You'll see a little dot where they got stung. That's the hole where they got stung with, but there's no stinger in there. If they got stung by a bee, particularly a honeybee, there's going to be a stinger that's left in there with a barb. All right, treatment is local, ice packs, antihistamines. Steroids are pretty much of no value unless they have anaphylaxis. And anaphylaxis, you guys are experts at treating. Epinephrine, antihistamines, the usual things. All right, there are some worse bugs. This is a list of those. Where are the people here from Arizona? Anybody? There's one. You guys have cornered the market on, you did residency there. How many scorpion bites did you treat? All the time, yeah. It's funny because, I talk to people there, it's like, like big ugly scorpions? You go, no, if you get stung by a big ugly scorpion, you're fine. It's these tiny little ones that cause, she's shaking her head, all the problems with it. They have ion channel toxins, they're cholinergic. These kids, they have antivenom for them. And you guys, I think it's a clinical call when you give the antivenom and when you don't, on them, particularly in the kids. But they can get respiratory depression and all kinds of problems with it. So yeah, it's something to worry about. If I don't think any other state, I'm sure New Mexico and parts of California and stuff have the scorpions, but I don't think that Arizona is the one that's really known for them. The spiders, there's the brown recluse spider, and then the black widows. Again, the recluse spiders are more of a localized toxic effect, whereas the black widows produce severe muscle rigidity and severe pain with that. So the treatment for those is analgesia. All of them have antivenoms that are available, but it's rarely used for the spider bites. This is the red, white, and blue sign that you get from a brown recluse bite. Whereas if you get stung or you get bit by a black widow spider, it's going to be more the severe abdominal pain and rigidity that they get. So a lot of them are treated with the benzodiazepines to get muscle relaxation. All right. If you have these in your backyard, you probably should think about moving, all right? If you've got a Gila monster there, it's probably not, don't send Twinkie out to play in the backyard. These things have pretty much the usual suspects for their bite, but these don't have fangs that you have to bite and kind of chew on you to induce the toxin in you. Venomous fish, there's fish that have, the lionfish have spines on them. There's things like the blue ring octopus, it's got a toxic bite. If you really are interested in venomous things, particularly venomous sea things, you can go to Australia. They've pretty much cornered the market on things that'll kill you if you go for a dip in the water. Their life, amazingly, you talk to the people, anybody here from, there was somebody here from New Zealand earlier. Anybody here from Australia now? Their lifeguards are pretty much paramedics more than they are lifeguards. They don't care if you drown, but they're going to rescue you if you get stung by any of the millions of things that are out there that are nasty, or you get eaten by a crocodile, whichever. Seafood poisonings, this is not an envenomation. This is a toxin in the muscles of the fish that cause scromboid and the Chicardia toxins and those types of things. And then the invertebrates are the ones, like I said, in Australia they have all these venomous jellyfish and those kind of things. I never knew that the box jellyfish is a tiny little thing, but if you get stung with it, you get paralyzed from the pain and then you just drown. So I don't know how, I don't care how nice the day is and how nice the water looks. I'm going back to the pool if I'm in Australia. All right, when in doubt, it's a poison control center. That's where you're going to get some useful information. All right, we are 2 minutes over. Who's up? Richie, you next? I will, thank you. I will.
All right. Just a getting to know you question. I used to ask people, who's a nurse, who's a doctor, who's what. Let me get a generic question. How many of you take drugs regularly? Mimi and I, yes. It's amazing. I do that all the time and nobody cops to it. You take drugs, come on. You take Motrin, right? You take Zofran, right? Wine. What's that? Wine. Wine is a drug. That's hysterical. This morning when I used to get ready for lectures, taking a beta blocker, to relax and try to chill. And now I take amphetamines and and if I'm there 2 days before my talk, I take Ozempic in hopes of getting a quick hit and then some mushrooms. Anyway, so it's my call. Tox people get the best drugs. You don't want to know. All right, I'm going to give you 4 cases. Let's get to the real stuff. Everything you ever learned that matters, besides learning from your significant other, I hope, and the nurses in your facilities, everything important I learned from nurses. I knew that day one, when you started in your careers, you had 2 fears, right? Number 1, please God, don't let me kill somebody. It's not funny. And 2, who's the smartest person I can learn from? And I learned from nurses. Everything they ever told me had no secondary gain. There was no ego satisfaction. It was for the functionality of the division and the improvement of the patient's status. So that's my pitch. But you learn things, and you learn things from, I told you, med school first 2 years, sorry. You learn from your cases. Would that be fair? You do. And you make mistakes. Hopefully short-lived, scary as hell, never do them again mistakes. These are 4 cases where there are minor pitfalls you can make. Nobody's going to die. They're not going to lose their head. But they're important. Now, the world of tox is bifurcated into doctors and over-the-counter drugs versus the illicits. And I'm not doing illicits. It changes every week. There's a new illicit drug and whatnot. I think everybody here knows how to give Narcan. I think everybody here knows how to suspect an edible and things like that. But there's stuff out there that's really terrifying. So the objectives are simple. Number 1, how do you approach them? How do they work? Now, tox people, I'm a geek. I like biochem. Don't shame me. It's amazing. You like it or you don't. And I like to think about how it got there, how the cause and effect of transmitters and proteins and stuff. We like that. And then what modalities are there for you. So let's just keep it simple. I can't overemphasize this. I'm just going to move through it. A, B, C, D, and E. And the only highlight here is a couple things I've learned. Number 1, seizing people do not ventilate. We are all sluts when it comes to the first thing you ever streamed in your life was a cardiac monitor. You stare at it like it's the secret of life. How many times have you been in a critical situation, maybe with or without chest compressions, maybe with just bagging, and you stare at the monitor? You do, I do. And you look at SATs and you look at BPs and things like that, but you don't look at the patient. Now, before you were born, I did a study that was completely unsanctioned. the statutes run out. Anyway, seriously, febrile seizures used to get labs when they came in, simple febrile seizures. And we would do CBC blood culture. We overdid it. You heard that talk. We don't do that anymore. And I would throw in, just for S&G, giggles and whatever, a VBG. And the average, and I had over 200 patients in it. I didn't write it up. And they would have approved it. But the average PCO2 of those kids who are normal, fine, postictal, sleeping it off, the mom looks worse than them, was 63. They don't ventilate. To the bedside, you're looking at the monitor. It's a sick kid. Somebody's bagging. I don't know. I want to warn you that as I get older, you get younger, but the new respiratory therapists don't know how to bag kids. They don't. You got to do it. You got to do it. And they don't watch chest rising and things. So seasoning kids don't ventilate. Everybody's hypoglycemic. And the other thing is, if you just do this stuff, this is not a magic medical mystery world. There's no particular antidote. There's one I'll talk about where you'll be a heroine or a hero and, you know, and that kind of thing. It's just basic stuff. So let's get going. We live in a sick world. There's crazy stuff out there. Kids are victims. There's two peaks of poisoning in kids. There's accidental exposures by inquisitive kids under 5. Those of you who have kids know what I was saying is true. Kids are born, right? They get 2 APGAR scores, and then they try to kill themselves. My grandkids came to visit, and I had to poison-proof my house again. One of my grandkids is not one of my favorites, so I didn't tell her where the bad stuff was. But anyway, her name will come to me. But have someone else get more history. Nobody gives you the whole history. And Hillary Clinton, no politics, said it takes a village to raise a child. And in our downtrodden society, often the child spends a lot of time on the block. Grandma so-and-so, the creepy guy in the corner, I don't even want to think about it, but there's stuff around. So you got to have somebody in history. Look it up. Don't be shameful with yourself. Google it, what they're taking. There's a lot of weird stuff out there. And call Poison Center. And the one thing I didn't put in is the paramedics who pick the kid up, send them back to the house. How many times have you asked somebody, what meds do you take? And they look at you like you asked them where Jimmy Hoffa was buried. I mean, they don't know anything. So use that. And don't be, I already put this in. Now, let's see if we can get to a case, because I want to get to it. Small outside hospital. It's one of my favorite linguistic phrases. No one's ever said small inside hospital. I don't get it. 15-year-old intentionally takes 100 tabs of 500 milligram aspirin, okay? Aspirin is back. Cardioprotective aspirin is back. 81s. I'll ask, how many of you are taking cardioprotective salicylates? Some of you are lying. It's okay. It's in every household. And 15-year-old, you know, let me ask an easier question. How many of you would rather die than take care of an adolescent patient? I like to be able to help somebody. It's not going to work. They open the drug cabinet and they just scoop and run, and they'll often take it. No 2-year-old is going to take a lot of salicylates because they taste like rug. They're not going to make a Cheerios bowl out of it. So it's an older attack. All right, small outside hospital. The physical exam is here. Vitals are listed. Pressure's acceptable, a little tacky. Good SATs, normal temp, so far so good. Slightly confused, appropriately interactive, admits that she took it. Pupils work, and there's no redness to the throat, airway works, and tachypnea, tachycardia, and wait for it, hyperpnea. Hyperpnea is different than tachypnea and matters to us. Whenever I see hyperpnea, I think of metabolic acidosis with compensatory respiratory alkalosis to blow it off, okay? It's a big thing. The belly works, pregnancy is negative, MS exam is fine, warm skin, mild diaphoresis. Okay, somehow I'm getting dupes here, but here we go. What do? Airway, breathing, circulation. Dextrose stick is 90. You give a little bolus maybe, and your cardiogram is fine. There's no torsades, no QT interval prolongation, no degree of depression is kind of normal. So you're hanging out. You got nothing. No action agenda is happening. And for some reason, these are all duped. But this is your problem list. Hold on with me. We'll get to it. So salicylates, quick hits. Here's the teaching point. Salicylates do 2 bad things to you. They stimulate your breathing control center. and you get a respiratory alkalosis, primary respiratory alkalosis, primary. You can see 1 million compensatory respiratory alkaloses in your career, diabetics, sepsis, whatever. Not many things cause primary respiratory alkalosis: brain tumors, colchicine, and salicylates. But salicylates is number one. So your pH is going up, and that's your primary. At the same time, it uncouples oxidative phosphorylation. Now, don't try to strain your brain. It basically turns you into an anaerobe, and you become lactated and acidemic, and you have a primary metabolic acidosis, primary resp alk, metabolic acidosis. They're fighting, okay? And acid-base, and they can actually have normal pHs because they kind of neutralize each other. You'll see where this comes in. There's somebody's cursing me. I think it was that woman who left. So there's a whole backstory on that. So sorry about that. That was fun. Respiratory alkalosis, I told you, and metabolic, they mix up, and you don't want to mess with the balance. And you'll see where this goes. Sorry, the rest of them won't do this. So here's your BMP, and just to remind you, the bicarb is low. That's all you got here, people. She's acidemic. She's got a base deficit. Fits. Primary metabolic acidosis. And the PCO2 is obviously low. Chloride jumps up to fill the gap. And here's the pH, 736. Look at the PCO2. She's sick and out of it, yet she's ventilating down to 26. That's primary resp alkalosis. She's got a salicylate level of 67. We'll do it in another case, but how many of you remember the mnemonic mud piles? I don't know what it is. We remember that. As for those of you getting older, the problem with mnemonics is you remember the letters, but not what they stand for. It's a minor point. And there's Tylenol level is negative, and I won't harp on it, but everybody you get your tox workup gets a Tylenol level because you can treat the overdose. All right, do the things. Bicarb, bolus, and drip. She took an acid, give her a base, alkalinize the urine, it'll suck it out. That's Biochem 101. Trend labs, call nephrology. I love nephrology people. They actually help you. They're so smart. They really are. And they give suggestions. And you need them for two reasons: to analyze the numbers and to dialyze. And call them early, call them hard. And they love dialysis. Why do they love dialysis? It's a level 5 visit, and they can build the hell out of it. And monitor closely. Okay, I don't want to dwell on it. But what happens if she gets tired? Okay, she's getting tired, and she's no longer going to have the respiratory alkalosis. That acidemia from the metabolic is going to jump. And I've seen in an hour the pH go to 6.9. So you got to ventilate. And why do we worry? I told you why. You give them a bicarb bolus, optimize the vent settings, ask for help, repeat labs frequently. If you take a look at her, she did well. They dialyzed her. Dialyzing fixes everything. You can get anything you want off. So that's salicylate case. You know the physiology of it now. You hang your bicarb, you call nephrology in the poison center. Many don't need to be dialyzed, and they'll all get better. The people who get into trouble with salicylates are the elderly who self-medicate over 5 days, not a 15-year-old who does it on a Tuesday. So that's our first case. And this next case is one of my favorites. This is a case that I completely blew, but they lived, and I'll never do it again. Boy, did I blow this. This is a 2-year-old who was fine, 4 hours of irritability and sleepiness. She was at a family house. She went outside in the backyard and came back acting funny. She returned to the home strange, okay? The vitals here, her temp is 37. There's nothing here on the vitals, no help. In general, she's sleepy, irritable when stimulated, but she responds to being ticked off, okay? However, there are things that are going on. Her pupils are anisocoric. 8 to 12% of the general population have unequal pupils. So the natural question is for me to ask the mother, have you noticed they're having unequal pupils? Like you would ask somebody, has anybody ever mentioned a murmur in your kid? And the answer I usually get is, I don't know, I just met the kid in the waiting room. They don't know. But let's see what we're up against here. Neurologically, she's focal. All right, we have a focal deficit in a 2-year-old, all right? For those of you who take care of adults, you know it's stroke protocol time and all the fun stuff, but let's get a look at it. Here's the pupils. But they work beautifully. They're consensual, they accommodate, they do everything. Okay, I'm happy. The problem list, number 1, altered. Number 2, unequal. Number 3, focal deficits. But the biggest problem is that I'm going to have to consult neurosurgery. Consulting neurosurgery is reaching out to an old girlfriend or boyfriend and asking them what you did wrong. Sit down, get a cup of coffee, and listen. I never bonded with neurosurgery, especially residents. In fairness, their main job is to not bother their attending and keep them in the OR. But it's the international sign for consult, the sign, stop. Consult is that. It's never a neurosurgical problem, right? I'm going to get a phone call one day about a beheading in the field, and I'm going to call neurosurgery, and they're going to say, call ENT, it's a neck problem. But I'm going to have to call them because it's the real deal here. Okay. Let's take a look. And this is, if there's one slide you want to take a picture of or look up, it's this one. These are my 4 touchstones. In the first 10 to 15 minutes, I got to get off the table in an altered kid. Number 1, and let me go to the next slide, which tells you what I'm going to do. Sorry, bear with me. I'm going to image this kid. This kid does not go into PCARN world. This kid goes to the scanner. You all would do that. That's fine. He's focal. Number 2, meningitis. You're thinking, oh, this can't be. I don't care. Nobody ever died from me getting a blood culture on a kid in a urine and pushing ceftriaxone or some drug, and then I've got time to tap him. You got hours before you mess up your tap, so I will do it. Opioids, Narcan, for everybody. I don't care what they're doing, if they're agitated or not. When I did my tox fellowship at NYU at Bellevue, I trained, I was blessed. I had Lou Goldfrank. I had to do adult shifts, New York. And one of my first patients was a junkie. Now, I live in Syracuse. We're pretty nice people. And my sinister vibes were off. And I gave this kid Narcan. And he wakes up, and he starts chasing me around the ED. And I go to the New York veteran nurse, and I said, what do I do? She said, you woke up the asshole. You deal with it. And I said, I'm home. I grew up in Manhattan, so they didn't like me. But Narcan, just give it. And then hypoglycemia, measure it. So let's keep moving. These are things that people talk on rounds in internal medicine. You got time on this. But I should have put this in. 30% of newly diagnosed diabetics present in DKA. 30%. Nobody picks it up at home. Now, it's getting easier to pick up at home because there are a lot of grandparents with type 2 diabetes who have finger sticks and urine dips. And often the grandparent suspects diabetes, type 1, in the kid. So I don't want to harp on that. You got a little time here. Here's a mnemonic. I love this one. And Al will appreciate this. Everything in here we always know, but it reminds us about intussusception with lethargy, which is a fair thing. So put that in you've got that anyway. Lab results come back. CT normal. CBC is normal. We tapped them. Sugar's 10. Now it takes 40 minutes to get a BMP back. So what do you do when you get a lab that doesn't make sense? How many times do you repeat? Yeah, you repeat. It's like oximetry. It's my favorite thing to watch. You put an oximeter on the finger of a kid and it's crappy. So you put it on the other side of the kid in case the other half of the body's doing well. You don't see the irony in that? I think it's hysterical. And then you put it on yourself just to double check. Anyway, we got a sugar problem. I gave the kid sugar. Grandma lives in the home. Some of her glyburide is missing. And we gave him D50, and I spent $40,000 working him up, and I gave him a $1.12 drug. Mea culpa. I'm a PEM expert. I'm a tox expert. I missed the most basic presentation in the world. And basically, the take-home message is get a sugar on everybody. Kids have no glycogen. I had, in my ED, I put stickers above the door jamb that said Dextra stick with a question mark. It's just worth doing, and it's easy to do. Any serious illness, any GI bug, especially rota, and any odd neurologics. Now, you're saying to me, Dr. Cantor, what the hell's going on here? We have a metabolic abnormality with a focal deficit. How does that happen? The god of tox, Lou Goldfrank, taught me that hypoglycemia is the great imitator, and it can cause focal neurologic deficit. So circle that one. And this is my real suggestion. I want you to change the ABCs to ABCD, dextrostick. Just get sugars. Okay, we got to keep moving. This is a scary case, and this is real time in a real world in a real event. This is 4-year-old male, took pills from grandma's purse. Diltiazem. Tox people are terrified of a few drugs, poisonous mushrooms, some other ones, but calcium channel blockers and beta blockers are the road to hell. And 2 hours. You got 2 hours of an ingestion, all right? The vital signs are listed. Blood pressure is low, tachy, not a bad heart rate, breathing, good sats, temp is normal. Constitutionally, he's a bit sleepy. Pupils work, airway works, bradycardic, as I said, lungs are clear, okay? The belly is soft, non-distended. Bowel sounds, I always hate writing these because nobody really listens anymore, but if you do, they were diminished. Musculoskeletal normal, skin warm and dry. Okay, so we have a calcium channel exposure, unknown amount, 2 hours old. We're already looking Brady, all right? So what's the first drug you want to use? First drug. I didn't hear you. No, you're going to the end of the movie, Jack. All right. First drug. Bradycardic person, what's the first drug you use? Atropine, okay. You might have heard of it. The drug rep, it's so old, the drug rep is dead, and there's no pen. Okay. So let's, right off the bat, primary survey, we got that. Start treatment. Fluids and atropine. Nobody died from atropine. The odds of this kid having cardiovascular illness are 0. You can get away with it. So do it. Good news, it'll work. Bad news, it'll stop working an hour later or less. Calcium channel blockers in 60 seconds. Here's what you got to do. You got to protect the terminal organs, okay? And the way you do that is you got to block the calcium receptor. I mean, you have to stimulate the calcium receptor, or B, find another receptor to get the heart muscle working around it. And here's what you have in your buckets. Atropine and calcium. Why not? I don't care if you use chloride or gluconate, use calcium, and you'll get a half hour of fun, and then you will be holding the bag. This will not work. Then you use vasopressors and glucagon. And glucagon is indicated. Glucagon works around the receptors. You have a glucagon receptor. But guess what you also have? You have an insulin receptor on the myocardium. I never knew that in med school, to be honest with you. So HIET, H-I-E-T, is the current remedy, the Narcan of beta blocker and calcium channel blocker overdose. It's a workaround. You don't care what's going on with the beta receptor or the calcium receptor. It stims the heart. So your job is to take a normal glycemic person and hit them with a high dose of insulin and compensate with a high sugar flow. And it's a cure. Now, there's other stuff that's very funky, and leave that to the poison center. ECMO and fat emotion. Not important for our talk. And I can't emphasize it. What is high? It's high-dose insulin, euglycemia. Little insulin, little sugar, and 1 unit per kilo bolus. This is in your handout, and you titrate it. Takes some time to work. This is really rewarding. Now, this probably will happen in the PICU, because by then you'll have done atropine and calcium and glucagon, and they'll be up there, but you may have to do it. And watch I don't have to tell you what to watch for sugar. And you got to double up your insulin concentration because you're giving 1 per kilo. That's a lot of units. You know, a 20 kilo kid is 20 units. That's a lot. And work with it from there. And basically, the course outcome here is he didn't get better with the normal things. He got better on the epi. He started on height. He went to 4 units a kilo. That's 40 to 60. Pressors titrated down. And he went home 4 days later. That's it. Now you have an antidote, and it's height. And you can do this. We manage insulin all the time. All right, we're good? You guys still with me? Okay, this is called Bad Night to Be on Call. And I like this because it's basic physiology. And as practitioners, we kind of know this stuff. This is not the actual patient, but I wish he was. I love this kid. Okay, for those of you affronted, I have nothing to say. I know this kid. This is my neighbor's kid. This picture's so old that I took it with film camera. I cannot get rid of this clip art. I'm so sorry. He's an engineer. He's an aeronautical engineer. I think he made the Boeing planes that crash. But I love this kid. All right, here you go. 4-month-old, chief complaint of barfing and looking ill, not helpful. His stools happen frequently. This kid had rota back in the day. Has anybody ever seen rotavirus? Rotavirus is the Dead Sea and odor of the Dead Sea coming out of the tush of the kid. It's the end of the world. And they can't tell you if it's blood or not. The emesis is variable, and others at home got better. He didn't. In fact, he looked pale and ashen, so they got freaked out and they brought him in. So if you look at the vitals, his temp is 38, heart rate's 140. He's tacky. His sat and room air is 88. What do you do? Come on, take a leap. You want to give him oxygen? All right, so we put him on 100% mask. It didn't change. It's 88. At this point, our most veteran nurse, and I can't say enough good things, but I got to warn you, in all your careers as educators and nurturers, you will morph towards the end when you're burned out from a nurturer to a neuterer, because you're just so tired of this shit. But so Marianne comes in the room, and she's looking at the monitor, and she goes, it's 88. How much O2 is he on? I said 100%. She goes, well, give him more. I said, I'm thinking for it, because she's smarter than me. I think, can we get more? Yeah, on Venus. Come on. So that's bad. All right, he's tired. His lungs are clear. Beautiful thing about kids' heart and chest is they don't have COPD. Their PA diameters are great. You hear everything. Sometimes you hear too much. You hear the heart, and it's a millimeter away from you, so you're in. A word about a pet peeve. Al talked about otitis media, or Simone did, in a neonate. Who are you kidding? You can see the TM in a baby. You look in there, it's like going to like Raiders of the Lost Ark. Another pet peeve. If the heart rate is, all right, 140, and you're clicking away on your EMR, just take a step back and don't bullshit me. This is 140. You ready? You hear a murmur, you're tripping. The med student hears a mid-diastolic diamond-shaped crescendo murder. Let them live in their dream. I want them to put in the EMR heart beating. Regular, maybe. All right, that's all I got for you, and the lungs are great. Al, I'll ask the question. How many of you percuss? Ever do percussion on the lung? Not so much anymore, huh? Nobody? Does anybody heard of it? Okay, feel better. All right, this is the vitals again. He's hypoxemic, and the problems are not good. This is important. All right, so his pulses are fair. Good cap refill. There's not a lot to go on here. He's just blue. And 88, 88, 88. So I'm sorry it's duped out. I'm going to format this. But so at this point, you know what you're going to do. And if you take a look at the workup, here's the symptom complex. Hypoxia, he's a little pallor. No murmur, I can say that. Clear lungs, and he's got diarrhea in the history. In fact, he's actively stooling when he's in the bed. All right, so I don't know what to do. So here's what we're going to do. This is the curse. Is it you playing this on a PC or a Mac? Thanks a lot, Bin Laden. All right. All right, so he's septic. Could he be septic? Everybody's septic. Everybody, all babies who don't look good and look like they're going to die are septic. No one will fault you if you do a blood culture at the bedside and push ceftriaxone. Just get it over with. All right, number 2, volume replacement. Kids, if anybody, can handle a bolus. So he'll get a bolus. Number 3, he's blue. Cardiac versus pulmonary and other. Another, it's one of my favorite lines. You got to give him ceftriaxone because one of the leading causes of cyanosis in children is ceftriaxone deficiency. It would be like Zithromax deficiency in adults. All right, so we did it. We ran the algorithm here. And you'll see, unfortunately, I love a PC. All right, evaluate intervention response. SATs are 87, 87. Chest film normal. Here's your ABG, and here's the deal breaker for you. Look at the gas in 100% O2. The PO2 jumps to 300. The SATs stay at 88. That means that he can dissolve oxygen in the blood, bubbles, but he can't carry it. This is the whole case. You can dissolve any gas in a fluid You fart in a bathtub, you got a gas. Didn't really think that was going to come out, but you can do it. So what's going on here? All right, let's keep moving. He's got methemoglobinemia. He's got hemoglobin poisoning. That's when iron in the heme, this hurts, it's old school. Iron goes from ferric to ferric, and you can't carry oxygen. Now, how did he get methemoglobinemia? The etiologies are nitrates are out there. There's amyl nitrate, I'll talk about it in a minute. Nitroglycerin, as a long-standing Jewish person, if you eat enough kosher hot dogs, you could probably get methemoglobinemia from the nitrates. Does anybody know what amyl nitrate is? Ever heard of it? Snappers, pop, well, Mimi just agrees, but you really, no, you guys gotta hang out with me. I get the good drugs. Amyl nitrate was a spanchule, like those ammonia capsules from the 50s where they woke people up from the noxious stimuli. Amyl nitrate is a cardiac dilatory drug before they had nitroglycerin. And what they used to do is pop it, that's the word, and it would work. It was discovered in the 70s by the rave population, predominantly the LGBTQ population for some reason, as the world's first Viagra. It's a nitrate. And the clubs, and I've been to them, people would be dancing away, having a great time, and popping them. I tried one once, full disclosure, and all I got was a migraine. It's a sad night. But the reality is, it's still out there. You can buy this stuff. The second group of drugs is benzocaine and lidocaine, and this is more realistic. You can see kids who have teething, and the parents buy Ambisol. I don't know what you're going to buy your son. I would use ketamine. But they're idiosyncratically sensitive to amide anesthetics, and we see these cases. They get transient methemoglobinemia. Quinones, sulfonamides, and naphthalene, mothballs. Pop quiz answer. I'm a teacher at med school. If somebody's pimping you for an answer and they ask you certain questions on rounds or whatever, there's certain BS answers I want to teach you. One, how does this drug work, they ask you. And you don't know nothing. And you just come out with, well, I think prostaglandins may have an effect. And no one else knows, and you look good. And the second one is with sulfonamides. If somebody asks you what drug causes this skin, brain, joint reaction, just say sulfa. Just pin it on sulfa. But these are the drugs that are out there. The treatment is you treat blue with blue, methylene blue. So you're going to take a blue kid and hang a blue bottle of liquid next to him. Now make sure you tell the parents that you're not making the kid blue by the bottle. A lot of my parents, I don't know about yours, are not, what's the kind word, brightest bulbs. And I once got shoved against the wall. He says, get that shit out of my kid, you're making him blue. And thinking not the world is not an even place. But meth blue always works. I don't want to bore you with the dosing. It's a miracle antidote. The case progression was his level was high. He got methylene blue. He grew roto. And you're saying, what the hell does rotavirus have to do with met heme? This is what it does. It's a long sentence. When you have malabsorptive large bowel diarrheas, you create nitrates in your large bowel. And you have a nitrate ingestion without eating it. It's just made endogenously. There's about 78 case reports of this. It doesn't matter how he got here. You got to turn him around. And the second teaching point I should put in, if for some godforsaken reason, the SATs in methemoglobinemia are always 87 or 88. I have no answer and why for you. And basically, the take-home message, this is how you breathe and get oxygen. Number one, you breathe it, lungs. You carry it, heart. You pump it, hemoglobin, okay? Hints, use the hyperoxia test, which I'll show you. Mid-80s or methemoglobinemia. I'm not going to bore you with this table. It's my favorite about how you distinguish it with PO2s and whatnot. It's in the handout, and I want to finish on time.
So a little bit before we go to lunch break, we do have some questions for our toxicologic adventurers. And I think, well, one, I will just put in a plug for poison control. Yes. I know that let's just give ourselves some grace and say, even with our expertise,
yes, get help.
And I think it's beyond just, even if I know what to do with Tylenol overdose, the kid's gonna come in the hospital and their continuum of care will be better if the poison control team is able to continue to help my team upstairs render that excellent care as well. So I look at you know, getting poison control involved, even if I know exactly what I'm going to do, because I look at it as a way to ensure the kid is getting the proper care regardless of where they are. In addition, every time I call poison control, and you can correct me if I'm wrong, Richie, I help support their existence for when I do call them and I have no idea what's going on, right? So if we only use them, if we only contact them, you know, on the one-off time that I'm not sure what to do with this, then when I do get into you know, a sticky wicket, they might not have the funding support to be there. So I look at calling them. I have a very low bar for if there's any intoxication, any ingestion. I just say, hey, I'm pretty sure this is what's going on. This is what I've already done. And they're like, sounds great. We'll keep track of them. Wonderful. You know, versus, oh no, you need to, oh, I forgot about high dose insulin. By the way, let's just talk about high dose insulin. Are we seriously, give me that dose again?
1 per kilo, one unit.
1 unit per kilo. And that is considerably different than what we do for DK, right?
Yes, sir.
So having done this before, it is a sphincter puckering moment when you hang that dose up.
Take a breath.
And so my question, and the question
15
here is,
calls from pharmacy before you're allowed to actually start it.
how
so
much
it's fine.
glucose do you need to infuse continuously to offset that dose of insulin? Because
I'll give you a secret. If it's a toddler, I've actually given them orange juice to drink or a sugar drink, because there's an unknown fact in peds that hypoglycemia is better treated with endogenous sugar than exogenous sugar.
Mm-hmm.
It's like if anybody had an infant of a diabetic mother in the nursery, a big whatever, and you're running a lot of sugar into them to fight the insulin, the minute you feed them, they get better. But in lieu of that, you would use basically 50 grams of glucose per liter. And you can just match it. It's like Battle of the Network Stars. I mean, it's a fight. But it's a lot of labor. So get them up to the PICU.
Yeah.
Because your nurses will kill you.
And
it works great. Works great.
And I find that having done this, they don't get as hypoglycemic as I think they should.
They don't.
Like the beta blocker overdose that they're, you know, currently fighting, the insulin somehow is directed towards, you know, mitigating that rather than causing them to be hypoglycemic. Don't get me wrong, we should think about them becoming hypoglycemic because I'm giving them truckloads of insulin, but it doesn't seem to be as prevalent of an issue. Like our team doesn't seem to be chasing their tail with the hypoglycemic events as much as what we do get in trouble with DKA sometimes.
Sadly, the obesity epidemic in the country does not spare children. You know what I'm talking about. These kids are just too large too early. And I go to a mom of a 3 or 4-year-old and say, like, listen, you know, I got to talk to you. I'm always a Gen Peds person at heart. I said, your child weighs too much or large. They don't know what a BMI is. And they'll go, I don't understand it. I said, well, you feed him. I said, unless this kid has a private Grubhub account or has perfected photosynthesis, it's on you. What I'm alluding to is the reason we get away with it, these kids are big and they have a lot of glycogen.
Which does then, you know, we've, I think, touched on another interesting case where you had the focal, I need someone to explain the focal finding of the kid who is hypoglycemic.
I call Dr. Goldfrank every 3 years. Has anybody heard of Dr. Goldfrank? I mean, my icons are all dying.
Yeah.
Okay, if
He's
he
a
told
book.
me the sky was falling, I'd get a helmet, all right? And I go, Lou, did we make up some BS about it? I mean, how does that happen that you have a focal? He goes, God's will, and stop asking stupid questions. And I don't know. Just
Yeah,
do
I
it.
will say,
Yeah.
you see it a lot in adults.
Thank
Correct.
you.
You do, and part of my rationale behind
You got a good one?
Yeah. One of the carotids is more obstructed than the other. One side's getting so many liters of blood per minute. The other side's getting half of that. You drop the sugar. One side's still getting enough. The other side's not. So
I'm going with that.
Yep.
Okay, I'm up. A
Yeah,
two-year-old with this.
again, on the adult side, to support what Al's saying, is we have activated innumerable code stroke protocols for people that just needed dextrose. And
Yeah.
nothing makes you feel more awesome than spending hundreds of thousands of dollars for someone needing some
Calling
orange juice.
neurosurgery.
Has anybody not been burned by hypoglycemia, altered mental status, getting that on like the BMP that comes back 2 hours later?
It's
Happens.
waiting.
all the
Like
time.
adults,
Yeah.
kids across the
Yeah.
board, I think every single person will get
Yep.
burned,
Just
despite
do
the
it.
fact that we hear it over and over and over again, right?
Yeah, and 100% true. My least favorite encounter of my career was when the seizing patient was not responding to the appropriate strategies we learned about the other day of, my benzos, and we were calling for all our second line, and we were thinking, Jim Homey and his love for ketamine, we're pulling that out. And the medical student goes, well, it was the patient's sugar. I was like, oh, did the medical
Who asked
student,
that?
did the medical student just like,
How much did you hate that?
yeah,
medicine?
no, they did not match at my program.
All good.
Did I say that out loud? I did, sorry.
All good.
We didn't have anything to teach them,
No,
right?
they were-
That's why at that point in time,
Yeah,
it was.
they clearly had gone beyond me. Here's another
Oh, God.
tox-related question. So you have someone who is presenting with an ill-defined ingestion. They're a teenager, they've, had seen better days, and they come in with a possible suicide attempt with an ill-defined ingestion. Do you get Tylenol and aspirin levels on all of them, as is common practice, or what's your thoughts on that? Tylenol and aspirin levels on all unclear ingestions?
Even clear ingestions.
Even clear
ingestions?
ingestions.
Yes.
Okay.
I think one of the biggest issues is the combined medications, right?
Thank you.
NyQuil PM has what in it? Stuff.
Has
I don't
stuff
know.
in it, yeah.
Stuff. It makes them sleepy and they're just goofy. Like find out what's in it, right? And find out what's in it that's actually going to matter, where we can reverse it, treat it, affect the downstream components of this patient.
Number one, I told you yesterday that everybody's trying to get us in the ED to stop overworking people up. Don't get the, shut up. Number two, I almost killed somebody. Thank you. I had this 2-year-old who came in with anticholinergic syndrome, dry mouth, blind as a bat, mad as a hatter, dry as a bone. And I was so excited. I'm a tox guy. I finally got one of these. I get to use physostigmine.
Ooh,
Which
nice.
is, this is
That is-
basic.
that is sexy.
This
Yeah.
is tox porn.
Tox
Okay?
porn.
This
Yeah.
is tox porn. And, all right, it's great. It worked. I'm asking the mother who was delayed, and what's around? What did he take? We got nothing on what he took. She barely met the kid. So, but I parked him. And I sent off, I didn't send off the basic labs because I was, what's the teaching term? Did I tunnel or anchor?
You anchored.
I anchored.
Yeah.
Premature closure.
I screwed.
Also tox
got it.
porn.
Yeah.
No, no, no.
Forget the tox part of it.
Oh, God. Well, it's just a bad image. Anyway, but the reality was, I mean, I blew it. And so my resident, who's a great resident, said, the labs are back. I said, and I came out of my mouth and said, why did we get labs? I'm so smart, I knew what it was. But Mimi's point, there's no single prep drug left anymore. What he took was Tylenol PM, which has a lot of Tylenol in it and tastes really good, the liquid. His acetaminophen level was 500. Oof. If I had blown it and parked him in the PICU and they didn't do anything, he's got a liver in 4 days.
Yeah.
Get them all the time.
Yeah, I mean, I think Tylenol is, it's everywhere, and
It's everywhere.
it doesn't have symptoms that you would be able to pick up on. Sometimes I think we can get a little academic with aspirin because,
Not anymore.
because you should, someone may say the aspirin overdose will have
Stuff.
findings that should alert me. The problem is they still could be subtle findings. Like I may attribute your heavy breathing to something else, and then I'm waiting and I get your labs back, and I'm just wasting time where, I try not to be too academic about Tylenol and aspirin. I just put them together. Don't feel bad about it. I think the moral of my story is don't feel bad about getting Tylenol and aspirin on, even if the individual, I think you said, no, I took 300 Seroquel. You're like, well, that's going to be a problem, but Tylenol and aspirin also. Because now your judgment is maybe not the best, and I can't in full faith take everything you said at, face value.
The other thing, I can tell you, my hospital, an acetaminophen level costs $40. A new liver is $5 million. It's important. The other thing is, quick word, I put on my tox hat. Urine tox screens suck. They're only as good as you spend money on them. I'm not getting into that. If you really want to do a CSI thing on somebody that they took something, just draw 5 red tops, okay? And and my colleague, Dr. Sacchetti, has invented a term. They're called digitubes. Digitubes are blood work that comes in a critical situation. He invented it, or he's the first guy I heard it from years ago. Like you have a hypoglycemic kid and he's seizing and you push stuff and they get better, and then you call endocrine down, right? And they go, did you get a growth hormone level? So those are digit. And then if you have the 5 red tops, you can go like suck on this. And then, I do say that. And they love you, oh my God. So the same with tox. Gas chromatography will find everything. Just draw them up and send them off on ice, you're covered.
I will say the one group I don't chase a lot of stuff is the IV drug overdose,
Oh, yeah.
the snorted, because they come in and you watch them and they get better. Nobody's shooting up acetaminophen.
Sure.
Yeah.
Sure.
That's true.
Yeah.
Although nowadays I have no idea what in hell there is on the street drugs because it just moves so fast now. For a while. Oh yeah, I mean they were shooting. It used to be just heroin. Then went heroin, fentanyl. And then it went to you shoot up this drug and your skin sloughs off, and then it's which is when that first happened. Xylazine. These people come in with these incredible stories. I'm like, oh God, I never saw leprosy. But that's exactly what it looked like. And then, then all the reports came out that that's what it was, and now we're on to something else. What's the latest? There's something else they're cutting it with.
Well, I would say that it's not
7-OH.
Yeah.
Not even just street drugs that we encounter. It's the stuff that's marijuana derivatives that are sold. We have this issue
station.
where I work. They're not legal in my state, but I live on the state line, so you just go a little bit south, and then South Carolina.
It's legal there?
Yeah, and at the
Border.
Yeah, at the gas stations, I've had numerous family members come in with kids that are just zombified, just drooling, staring, and you do these big workups, and mom's like, well, he was crying at the checkout, and he wanted these gummy bears. And you're like, not a gummy bear. That doesn't say Haribo on it.
Wait. Gummy
But
bears,
his sugar wasn't low.
the packaging, you all know the risk factors of gummy bears. Here's the real other issue. 99% of the gummy bears you buy are 5 milligram THC strength. It's 5. And per kilo, there's actually a per kilo dose. They're safe. You just get a little stupid. I was at a Passover Seder with about 40 people, ranging from my age down to 20, where some moron brought in edibles to give out, like, who wants an edible? And people do edibles.
Aren't you supposed to have like Manischewitz wine?
Yes,
And
yes,
Manischewitz makes gummies now?
Has anybody here ever been to a Jewish Seder? The drug you should take is a mushroom. But anyway, because it's really psychedelic. But no, this is a true story.
I got a mushroom
I
for
didn't
you.
partake, and people were acting funny. Like, you give a 65-year-old, and it turns out this effing moron, 50 milligram gummies, 5-0. I was going to run stroke protocols on the whole table. Nobody died. Read the label.
Speaking of mushrooms, we're always taught about the classic methadone, right, mushroom and the liver toxicity that comes with San Francisco, Bay Area, because of the rain that we had recently.
Oh, no.
Huge kind of outbreak, if you will, of mushrooms, right? And it turns out over the past maybe month or so, 3 people have died, 3 people on transplant. Because as it turns out,
Seriously.
people from other countries are used to foraging in their home countries, and they're like, great, these mushrooms are out, and they're just foraging the mushrooms, going home, mixing it up, making a meal, and coming in, and they were, the first case, second case, they're like, something is going on, and it was hitting families, and they were going, so.
Was this Amanita?
3 minutes?
No, usually mine.
It's not worth, oh, it is.
Was it Amanita?
So speaking of mushroom, no, we're like, Yeah. So because of this big blush of mushrooms that, because of the rain that we had, 3 died, 3 on transplants, and it was all over our news. Yeah.
You get the good
So
drugs.
a lot of it is, when it comes to toxicology, it's really fun because you get to play detective a little bit, right? Like, where did this come from? How did it go? And sometimes if I'm not sure what's going on with a patient, I consult rheum or toxicology because they are the best history takers that just pinpoint what the heck is going on. I say that not totally tongue-in-cheek.
Yeah.
You actually have rheumatology?
I tell them,
am impressed.
I tell them patient has bilateral joints. Could they help me?
Yes.
Getting back to the questions. Activated charcoal. When do you use it?
Who are you kidding? Any 2-year-old who voluntarily drinks activated charcoal is decorticate. I've done that. You're going to wear it, and you should. The sad thing is it really works. Within 2 hours of an ingestion, and a lot of drugs slow the GI motility. Sorry. And it does work, but I got to tell you, your staff will want to kill you. And they make preps and whatnot, but the answer is 2 parts. It works, but good luck. Ipecac is gone. Throw it out. Unless you don't like some people and you go to their party and put it in the punch, get out fast.
Was that
We don't
Wedding
have
Crashers? Was that the
Yes.
Wedding Crashers?
I will say the only thing I've not had great success with the activated charcoal. Number one, drinking it, but number two, even when you get it into people, because whatever they took has a head start.
Yes.
So it's like it's in the ileum area, and you're giving them the charcoal is supposed to catch up to it. Unless it's undergoing intrahepatic circulation, I've not had good success with it. It annoys the hell out of the nurses in the unit, but.
Activated charcoal was created, this is how old it was, for phenobarbital overdoses, because it does have enterohepatic recycling.
Oh.
And that was the #1 drug. Worked great. You have a drug for this stuff, all this wacko stuff. It's called dialysis. Use it. It works.
I think our last question will be, again, actually it's regarding snake bikes. So
There you go.
There you go. The question is, can you clarify snake bite treatment for coral snakes, elapidids, versus pit vipers?
Oh, God.
They've had managed a handful of pit viper bites and previously told to avoid compression specifically due to it worsening local edema and tissue necrosis. And the question is that valid or not?
It's not so much compression, it's a pad that you put on there that's immediately local to get it so it doesn't move through the lymphatics. It's the lymphatics that you want to take care of. The idea being, though, this is pre-hospital, it's not in the hospital, because pre-hospital, you want to minimize it getting into the central circulation and producing systemic effects, because you don't want somebody going into hemolysis or shock in the field. Once they get to the hospital, you can manage those things. Interestingly enough, last week, an article came out of treating the pit viper bites with botulism toxin, which is kind of interesting. The idea is you inject it around the area and it prevents the inflammation.
Works.
Yeah, that you see there. It was some poor rabbits injected them with the toxin, then some got botulism, and their wrinkles went away and their legs did fine, and the others the legs fell off. So
were those not lucky rabbit's feet?
Yes, the
unlucky rabbit.
Yes, that's exactly right. But at any rate, it's probably coming down the road. So I can guarantee you I can get Botox quicker than I can get any antivenom. So.
If I could give you one poison prevention tip, I'll put on my tox hat. Next time you go to your parents' house, or your own, open your medicine cabinets. We still have those, right? It's astonishing. Nobody ever throws out a prescription.
Yeah.
My mother, who's gone now, but she was in retirement Florida, and I opened up her medicine cabinet, and it was the history of pharmacology. She would always come out and say, "Can I take this?" And it was like penicillin from 1948. And there's only 2 possibilities. It's either inert or might work. I don't know. This was from Alexander Fleming's lab, this pencil. And I would always say to her, "Do it." I wasn't that close to my mother, but it really wasn't. But the punchline here is you won't believe what's in there, and do them a favor, throw some of it out, because they're going to get old and crazy like me and make a mishap. And they'll do
All right,
Proper-
as
proper
somebody,
disposal.
as a grandparent now at my age, I don't throw things out readily. But what I found is the shelf it's not a medicine cabinet, it's one of the cabinets. When I have to start stacking the bottles on top of each other, it's time to go to the back and get some of them out. So whenever I get the 2 layers of bottles that I've squashed in
Lisa
there.
lets you do that.
Yeah, well, I do. I have. Well, the nice thing about it is you never finish your antibiotics. So there's always some back there.
Yeah.
So, if you have like a cellulitis or something, don't judge me. You guys do the same thing.
Well,
Yeah.
and what's really nice is like 2 pills of Keflex and 2 pills of Bactrim.
Yeah.
You just space them out over. You got 4 days
Absolutely.
worth of coverage, and that's
And the nice
phenomenal.
thing, where I'm come from, Lyme disease is endemic, so I've got
you
like
got some
the big
Doxy?
bottle of Doxy up
You
there.
got lots of Doxy.
So,
I have
Your
true
poor children's
confession.
teeth.
I cleaned ours out. In my experience, relationships are very difficult to begin with, but there's often mismatches that work. Like there's someone who's always cold who hooks up with someone who's always hot, et cetera. Somebody who's attention span hooks up with somebody who has none. But one of the things that happens a lot is a hoarder marries a dumper.
Organizer.
There's no gender here. I'm not being biased. It's a fact. And never the twain shall meet.
So Saketti's the hoarder?
oh, big time. My wife has a theory. If you haven't used it within 2 years, it's going.
Dumper.
So like, I'll look for something, and it's like, I know I had this. And she goes, when was the last time you used it? It was a couple years ago. It's
What's your
gone.
garage
Yeah.
look like?
Oh, the garage is my domain. But surprisingly, I keep it
Really organized.
Yeah, my workbench and everything is actually very cool. So,
With that, actually, any remaining questions to our
guys are
panelists
great.
Yeah.
before we break for lunch? Happy to field anything else. Certainly, you can continue to throw them up via the QR, and we'll circle back at the end of the day to cover anything else.
You want to tell them about your
Oh,
QR?
yes, maybe.
Oh, this was just the handout from the Learning Lounge. And what actually I will go back and add to it is the true positives, false positives on the urine drug screens. I'll add that to this, but this will be the QR code and I'll be able to update it.
And lastly, for all of you that are interested in watching these shows again, they're obviously being recorded. They will be available to you as participants via acep.org. So if you missed a portion, you had a senile moment and your brain turned off or something, you can always go back and see those things. Or if you would like to relive Richie's experience this morning, you'll be able to see that again.
or if you need
Over and over again, in
objective
slow
data
motion.
for when you contact whichever society he insulted the most, to give them.
That was freaked out, I got to tell you.
All right, thank you guys. Have a good lunch. We'll see you back at 1:30.
Our Pedsapalooza from the Pediatric Emergency Medicine Assembly from Accelerate 2026 in San Diego. Go ahead and make your reservations, sign up, and be ready to join us in Orlando in 2027, January, for this wonderful conference, wonderful faculty, so much great content, very high yield, and of course, incredibly entertaining if you've heard any of our PEDS-related podcasts over the years from these fine folks. And as for me, feel free to contact me, rstant@acep.org, rstant@acep.org, or at EverydayMed on X. And until next time, please make sure that you are subscribed to this podcast on whatever player you like. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
Far away to a quiet If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Ding. Quiet place, all
Yeah.
alone. Da, da, da.